Uh, I'm Dr. Saisham M. I'll be speaking about dysphagia, causes, evaluation, and the management of dysphagia. Dysphagia. This particular presentation consists of the definition, swallowing mechanism, the clinical presentation, grading of dysphagia, the etiology, the various investigations for when a patient presents with dysphagia, and the management of a patient with dysphagia. Moving on to the definition of dysphagia. The word dysphagia is derived from the Greek word phagia, which means to eat, and dys means with difficulty. It refers to the sensation of food being obstructed in the food passage anywhere from the mouth to the stomach. The basic impairment behind dysphagia are neurological, mechanical, or obstructive. Moving on to the swallow mechanism. The act of swallowing requires the passage of food and drink from the mouth into the stomach. From the mouth to the hypopharynx covers about one third of passage, while two-thirds is covered by the esophagus. The swallowing center in the brainstem is located in the floor of the fourth ventricle and adjacent regions of the medulla. From here, it is connected to the cerebral cortex, vomiting, and respiratory center. An adult swallow approximately 580 times daily, and the act goes on unconsciously. The various phases of swallowing are the oropharyngeal phase, which is under voluntary control, and the esophageal phase, which is under involuntary control. Moving on to the esophageal phase. The food bolus is propelled through the esophagus by an involuntary wave of contraction mediated by the enteric nervous system. Pressure gradient speeds the movement of food from the hypopharynx into the esophagus when the cricopharyngeus muscle relaxes. The primary peristaltic contraction, which is initiated by a swallowing, moves down the esophagus at the rate of 2 to 4 centimeters per second and reaches the distal esophagus in about 9 seconds. This duration varies from 8 to 20 seconds. The various clinical presentations that a patient with dysphagia might present with are pain and difficulty in swallowing, which is odynophagia, sensation of food being stuck in the throat or chest, coughing or gagging while swallowing, nasal regurgitation, dysarthria, nasal speech because of associated muscle weakness, frequent burning sensation in the chest, dyspepsia, unexpected significant weight loss. The functional grading of dysphagia is called as Takita's grading of dysphagia. Grade 1 when patient complains of dysphagia but still eats normally. Grade 2 requires liquids with meals. Grade 3 when the patient is able to take semi-solid but unable to take any solids. Grade 4 when the patient complains of dysphagia even to liquids. Grade 5 when the patient is unable to swallow liquid but able to swallow only saliva. And grade 6 when the patient is not even able to swallow saliva. Classification of dysphagia based on the etiology. Dysphagia is based on the site, maybe oropharyngeal or esophageal. Abnormalities causing oropharyngeal dysphagia are the inability to initiate the act of swallowing, which might be due to neuromuscular diseases, which might be attributed to central nervous system, wherein a patient might present with a cerebrovascular accident involving the brainstem, Parkinson's disease, Wilson's disease, multiple sclerosis, brainstem tumor. Neuromuscular diseases of the peripheral nervous system, such as poliomyelitis, peripheral neuropathies, which might be to diphtheria, tetanus, rabies, or diabetes mellitus. Motor and plate disorders such as myasthenia gravis, muscular disorders such as oculopharyngeal muscular dystrophy, primary myositis, metabolic myopathy, which includes glycogen storage diseases and lipid storage diseases. Mechanical or obstructive lesions include due to inflammatory, such as pharyngitis, abscesses, peritonsillar, parapharyngeal, or retropharyngeal abscesses, tuberculosis, syphilis. Neoplastic, Plummer-Vinson syndrome, extrinsic compression due to thyromegaly, such as Hashimoto's thyroiditis, cervical osteophytes, and lymphadenopathy. Disorders of upper esophageal sphincter, it is related to the abnormal upper esophageal relaxation or opening. Incomplete relaxation is seen in cricopharyngeal achalasia, oculopharyngeal muscular dystrophy, and inadequate opening is seen in cricopharyngeal bar, in Zenker's diverticulum, and delayed relaxation in familial dysautonomia. Esophageal dysphagia. Patient usually complains of feeling of food getting stuck several seconds after swallowing and will point towards the suprasternal notch or behind the sternum. The various etiological features include neuromuscular motility disorders, the most common including achalasia, diffuse esophageal spasm. Other motility abnormalities include nutcracker esophagus, hypertensive lower esophageal sphincter, motility disorders secondary to scleroderma, collagen disorders, and Chagas disease. Mechanical or obstructive causes of esophageal dysphagia being esophagitis. Dysphagia is due to mucosal edema or benign stricta. Gastroesophageal reflux disorder. Infectious esophagitis is seen in HIV, H. pylori infection, herpes, and candidiasis. Medication-induced esophagitis includes NSAIDs, quinidine, potassium chloride, vitamin deficiency of B complex, iron sulfate deficiency. Radiation treatment, caustic injury. Disorders of the wall include esophageal strictures, Zenker's diverticulum, epiphrenic diverticula. Diseases causing external compression include hiatus hernia, mainly the paraesophageal hernia, cervical osteophytes, mediastinal growth, vascular ring, that is dysphagia lusoria, luminal obstruction, foreign bodies, esophageal webs, Schatzki's ring, carcinoma esophagus. This table demonstrates the associated symptoms and possible etiologies of dysphagia. When a patient presents with difficulty in initiating swallowing, it means that one should consider oropharyngeal dysphagia. When the food sticks after swallowing the chest, it might be due to esophageal dysphagia. Progressive dysphagia is seen in neuromuscular dysphagia and in carcinoma of the esophagus. Sudden dysphagia might be seen due to a foreign body stuck in the esophagus or due to esophagitis. Intermittent dysphagia is seen in patients with rings and webs, diffuse esophageal spasm, and nutcracker esophagus. When a patient presents with cough in the early in swallow, the patient might have a neuromuscular dysphagia. When late in swallow, they might have an obstructive dysphagia. Weight loss in elder patient with regurgitation, usually seen in carcinoma of the esophagus or in achalasia. Pain after swallowing is seen in esophagitis. Dysphagia related to solid foods only is seen in obstructive dysphagia. Solids and liquids is seen in neuromuscular dysphagia. Regurgitation of old foods and halitosis is seen in usually patients with Zenker's diverticulum. Dysphagia relieved with repeated swallowing is seen in patients with achalasia cardia. Evaluation. History, clinical examination, blood investigations including the hemoglobin, the total count and differential count, serum iron levels, a radiology including a plain X-ray to rule out foreign bodies in the esophagus, a barium meal to rule out various other conditions, a CECT of the thorax and neck, upper GI endoscopy, both therapeutic and diagnostic, a laryngoscopy to rule out any cricopharyngeal or pharyngeal syndromes, a manometry to rule out motility disorders of the esophagus, a 24-hour pH monitoring to confirm the diagnosis of GERD, an endoscopic ultrasound to rule out any extraluminal and staging of carcinoma of the esophagus, histopathology to identify the cause of the mass. The first X-ray shows a denture stuck at the level of the suprasternal notch, which is the starting of the cervical esophagus. And the second picture shows a pin being stuck, so both patients are present with dysphagia due to a foreign body in the esophagus. The first barium swallow shows a mid-esophageal diverticulum, wherein a patient might present with dysphagia halitosis and painful swallowing, odenophagia. The second picture shows an epinephric diverticulum, wherein you see a diverticula at the distal end of the esophagus towards the abdomen, that is at the level of the gastroesophageal junction. And the third barium swallow shows Zenker's diverticulum up in the esophagus and the upper cervical esophagus or in the upper one-third of the esophagus. Usually these patients present with dysphagia and halitosis. Here the first diagram shows a bird beak appearance, which is a pathognomic sign of achalasia cardia. And the second barium swallow shows a sigmoid esophagus, which is usually seen in a patient with a long-standing achalasia cardia. The third picture shows a nutcracker esophagus, wherein you have multiple areas of the esophagus contracting at the same time. The first barium swallow shows a stricture, a long segment stricture, which extends for more than 2 vertebral bodies, which might be seen in a caustic injury. And the second barium swallow shows a sliding hernia. The third barium swallow shows an irregular filling defect, which is usually seen in the case of carcinoma esophagus. Semiradiography or fluoroscopy. It is a dynamic assessment of the swallowing mechanism. The lower diagram show a radiological visualization of food bolus movement from the oral cavity into the hypopharynx. The first shows the contrast in the oral cavity, the second one at the level of the hypopharynx, and in the third diagram, the bolus has moved down into the esophagus. Moving on to endoscopy, it might be of two types, rigid or flexible endoscopy. It might be either used for visualization and biopsy, wherein you perform a diagnostic test, or therapeutic, wherein you can be used for a foreign body removal, stenting, and dilatation. The first picture shows Barrett's esophagus, wherein the squamocolumnar junction is moved above and there is intestinal metaplasia that is seen. And the second diagram shows a Skatsky's ring. The third diagram, a patient presenting with grade C esophagitis. And in the fourth diagram, you can make out a esophageal diverticulum at the level of the GEJ might be a possibility of an epiphrenic diverticulum. The first endoscopic picture shows a foreign body, probably a fish bone stuck in the esophagus. The second one shows a retro gastric view of the paraesophageal hernia, wherein you see the endoscope that is coming into the stomach through the gastroesophageal junction, and the other one being a paraesophageal hernia, wherein the stomach contents herniate into the thoracic cavity. The third picture shows you a corrosive stricture with multiple ulcerations, and the fourth picture, a proliferative growth in the esophagus covering about 1/3 to 2/3 of the circumference of the esophagus of a carcinoma esophagus. Moving on to manometry. The various indications for manometry include achalasia cardia, diffuse esophageal spasm, nutcracker's esophagus, hypertensive esophageal sphincter, and it might be of two types, stationary manometry or a high resolution manometry. The first diagram shows a normal peristalsis of the esophagus. The second shows a manometric reading of a patient with achalasia cardia wherein there is absence of any peristalsis at all. And the third diagram shows multiple peristalsis with high amplitude of greater than 180 millimeters of mercury, which is seen in nutcracker's esophagus. And the fourth one shows a diffuse esophageal spasm when greater than 10% contractions have a pressure of greater than 30 millimeters of mercury. 24 ambulatory pH monitoring. It is the most direct method of measuring increased reflux, that is the exposure of the esophagus to the gastric juice, which is done by an indwelling pH electrode or more recently via a radio telemetric pH monitoring capsule that can be clipped to the esophageal mucosa. This diagram just shows you how the electrode is placed at the level of the gastroesophageal, about 5 centimeters above the level of the gastroesophageal junction to monitor the pH of the esophagus and the reflux of gastric contents into the esophagus. Either it might be ambulatory, wherein a radio telemetry probe can be placed and clipped to the esophagus, or a nasotracheal electrode can be placed. Moving on to endoscopic ultrasound. It is used in the staging of carcinoma of the esophagus and can be used for both diagnostic procedures to acquire biopsies from extraluminal masses as well as mediastinal masses. It might be a radial echo endoscope wherein you look in circular concentric patterns, and a linear echo endoscope wherein you look forward. So the diagram on the right, A represents a radial echo endoscope and B represents a linear echo endoscope. This is the histology. First diagram shows an intestinal metaplasia of the lower end of the esophagus, showing multiple columnar cells, which is seen in Barrett's esophagus. The second diagram shows a squamous cell carcinoma, wherein you can make out multiple keratin pearls. And the third one, an adenocarcinoma, wherein you can see multiple layers of columnar mucosa. The treatment is basically lifestyle modification, drug therapy, therapeutic endoscopy, dilatation, stentings, chemoradiations, and surgery. We'll be dealing about the management of particular disorders in further presentations. Thank you.